Welcome back to the deep dive. Today, we are zooming in on a war zone that is happening at a microscopic level. But unlike the battles we usually talk about, usually it's humans versus bacteria. This one is, well, it's a civil war, or at least it feels like one.
Yeah, it really is a fratricidal war in a biological sense, and honestly, it is one of the hardest topics in microbiology to truly master because the margins are just so razor thin.
Right, we are talking about antifungal agents today, and I have Murray's Medical Microbiology, Chapter 61, open in front of me, along with a stack of clinical papers. And the first thing that hits you, the thing you really have to grasp, is the difficulty level. When we treat bacterial infections, we are fighting aliens, right? Prokaryotes, they are fundamentally different from us, but fungi.
Fungi are us. Well, nearly.
That's the eukaryotic problem.
Exactly. This is the fundamental anchor for the entire discussion today. If you look at a bacterium, it is a prokaryote. It has a completely different ribosome, the 70S ribosome. It has a cell wall made of peptidoglycan. It doesn't even have a nucleus. So it's an easy target because it looks absolutely nothing like a human cell. You can bomb it without really worrying about collateral damage to the host.
But a fungus?
A fungus is a eukaryote. If you put a human liver cell and a fungal cell side by side under an electron microscope, you would be uncomfortable with how similar they look. We share the same DNA organization wrapped in a nucleus. We have mitochondria. We have the exact same ADS ribosomes.
Which means you can't just throw a grenade in there.
Right. If you target the ribosome to stop protein synthesis in the fungus, you stop human protein synthesis. If you attack the DNA replication machinery blindly, you're essentially giving the patient chemotherapy.
So this is what we call the mirror image problem. Targeting the fungus is like trying to poison an evil twin who is standing right next to you holding your hand.
Without poisoning yourself.
Yeah.
That is the central challenge of antifungal pharmacology. Selective toxicity. We have to find the tiny microscopic disconnects between the human reality and the fungal mirror image.
And according to our sources, that solution, that disconnect we are looking for, almost always comes down to the envelope, the wrapper of the cell.
But the cell envelope is our map today. We can't attack the engine room easily because our engines are too similar, so we attack the hull. Humans have a cell membrane. Fungi also have a cell membrane. But the glue that holds that membrane together is different.
We use cholesterol.
And they use ergosterol. It is a difference of just a few atoms, mostly in the side chain, but it's enough to drive a wedge in.
And there's a second layer too, right? A layer we don't have at all.
The cell wall. Humans are soft and squishy. We have membranes, but absolutely no rigid walls. Fungi are armored. They have a thick mesh of chitin and glucan outside their membrane. That is a massive target for us.
So, here is our mission for this deep dive. We are going to navigate Murray Chapter 61 by categorizing these drugs based on exactly where they strike on this map. We are going to look at the membrane disruptors, the heavy artillery that punches holes. Then we will look at the architects, the drugs that stop the membrane from being built. We will look at the wall breakers. And finally, the distinct few that actually manage to sneak into the nucleus.
It's a great structure. And as we go through this, you should keep that mirror image risk in mind for every single drug. Because every time we attack, there's a potential cost to the human host.
Let's start with the heavy artillery. The oldest and arguably the most violent weapons we have in the arsenal. The Polyenes.
The Polyenes. And the celebrity here, the gold standard for over half a century, is amphotericin B.
Ampho. Even the name sounds heavy.
It is heavy. It's a massive molecule.
Yeah.
And its structure tells you exactly how it works. It is amphipathic.
Break that down for us. Amphipathic.
It means it has a split personality. Amphi means both. On one side of the molecule, it is covered in hydroxyl groups, making it hydrophilic, meaning it loves water. On the other side, it is a long chain of double bonds, making it lipophilic, meaning it loves fat.
And this specific structure allows it to play a very brutal trick on the fungal membrane. Murray uses the metaphor of a barrel stave.
That is the classic visualization. Imagine a wooden barrel. The staves are the vertical planks that make up the walls of the barrel. Amphotericin B inserts itself into the fungal cell membrane just like those planks. The lipophilic side faces outward, interacting with the membrane lipids because lipids are fat. The hydrophilic side faces inward towards the center of the barrel.
So it creates a tunnel.
Exactly. It forms a pore, a literal hole in the membrane. And it doesn't just float there randomly. It binds specifically to ergosterol. It grabs the ergosterol molecules and pulls them together to stabilize this tunnel.
Right, so you have basically punched a hole in the ship.
A donut hole, as some textbooks call it. And once that hole is open, the laws of physics just take over. The fungal cell is full of potassium, magnesium, and other vital ions. The outside environment is entirely different. So everything rushes down its concentration gradient. The cell leaks its vital fluids.
It bleeds out.
Metabolically, yes.
Yeah.
The proton gradient collapses. It can no longer make ATP. It dies. This is why amphotericin is fungicidal. It doesn't just ask the fungus to stop growing, it executes it.
But Murray mentions it's not just the leak. There is a double tap mechanism here.
Yes. We used to think it was just the holes. But we now know that amphotericin B also generates oxidative stress. It enters the cell and triggers the creation of free radicals. So you have physical damage to the envelope and chemical damage to the interior. It is a really brutal drug.
Brutal for the fungus.
Yeah.
But we have to go back to the mirror image problem. You said it binds to ergosterol, but ergosterol looks a hell of a lot like cholesterol, which is the exact molecule holding my cell membranes together.
And that is the tragedy of amphotericin B.
Yeah.
It prefers ergosterol. The affinity is roughly 10 times higher for ergosterol than for cholesterol. But, and this is a big, but 10 times isn't infinity.
It's close enough to miss.
Exactly. If the concentration is high enough, or if ergosterol is scarce, amphotericin B will absolutely bind to human cholesterol. It will punch holes in human cells.
And this is why they call it amphoterrible in the hospital wards.
It is a nickname earned through shivering patients and rising creatinine levels. The toxicity profile is significant.
Let's talk about that toxicity because it's not some vague, generalized toxicity. It hits specific organs.
The kidney is the primary victim, nephrotoxicity. And it happens in two distinct ways. First, because of that hole punching mechanism, it directly damages the cells of the renal tubules. It punches holes in your kidney cells.
And the second way?
Vasoconstriction. It squeezes the afferent arterioles. Those are the blood vessels directly feeding the kidney. So you are chemically damaging the filter and choking off its blood supply at the exact same time. Almost everyone on the classic formulation of this drug will see their kidney function take a hit.
And it's not just the kidneys. There is the shake and bake.
The infusion reaction. This is immediate. You hang the bag, start the IV drip, and within an hour the patient develops violent rigors, shaking, chills, fevers, and sometimes profound hypotension.
What's actually happening there? Is that the holes too?
That is actually an immune response. The drug triggers a massive release of pro-inflammatory cytokines, tumor necrosis factor, interleukin-1, from the patient's own immune cells. It's basically like a simulated sepsis.
Yeah.
We have to pre-medicate patients with Tylenol, Benadryl, sometimes even steroids, just to get the drug into them safely.
Now, science has tried to solve this. We have the lipid solution. We moved from the old deoxycholate version to the lipid formulations. How does wrapping the drug in fat solve the problem?
It is a brilliant delivery hack. We package the amphotericin B inside liposomes, or lipid complexes. Think of it as a microscopic fat bubble. When this bubble is circulating in your bloodstream, the amphotericin is sequestered inside. It can't interact with your kidney cells nearly as easily.
So it just floats past the kidney without punching any holes.
Right. But here's the clever part. When it reaches the site of infection, where the fungus is actively growing liposes, which are enzymes that break down fat, or just the inflammatory environment itself break down the bubble, or the fungus itself, having a much higher affinity for the drug, pulls it out of the lipid complex.
So it's a targeted delivery system. It holds the drug in reserve until it sees the enemy.
Precisely. It drastically reduces nephrotoxicity, but it is exponentially more expensive. So in resource-limited settings, the amphoterrible formulation is unfortunately still the standard.
Let's talk about its spectrum. If this is the heavy artillery, I assume it hits a lot of targets.
It has the broadest spectrum of arguably any antifungal. It is the broadsword. It covers yeasts like Candida and Cryptococcus. It covers molds like Aspergillus. It covers the dimorphic fungi, those shapeshifters like Histoplasma and Blastomyces found in the river valleys.
It even hits the bread molds.
Mucormycetes, yes. These are the nightmares that eat right through sinus bone in poorly controlled diabetics. Amphotericin B is one of the very few things that can actually stop them.
But because this is biology, there is always an exception. There's one specific organism that you need to know is intrinsically resistant to amphotericin B. This is a classic exam question.
Aspergillus terris.
I love the mnemonic for this one. Terreus sounds like terrain, earth.
Right. Terreus means earth. If you are on the earth, you are grounded, you are resistant. Aspergillus terreus produces less ergosterol in its membrane or relies on slightly different sterols, so the amphotericin just cannot get a grip.
So if you get a culture report back and it says Aspergillus terreus, you put the ampho away, it's completely useless.
Correct. And our Jalvet source throws in a modern curveball here that we have to mention. Candida auris.
The emerging pathogen everyone is talking about.
It is way more than emerging at this point. It has arrived. Candida auris is displaying variable resistance to amphotericin B. Some studies show up to 30% of isolates are resistant. That is terrifying, because amphotericin has always been our absolute safety net. If nothing else worked, we used ampho. With C. auris, that safety net is tearing.
Okay, so that is the membrane disruptor, the one that punches holes. Now let's move to section 2 of our map, the architects.
The Azoles.
This is the biggest class, right? The most names for you to memorize.
It is, but they all work the exact same way. They are the precision architects, or rather the saboteurs of the architecture.
Right. Amphotericin kicks down the finished wall. The azoles stop the wall from being built in the first place.
Exactly. The azoles are membrane synthesis inhibitors. They target a very specific enzyme called lanosterol 14-alpha demethylase.
That is quite a mouthful. Let's unpack that. What does this enzyme actually do in the fungal cell?
Imagine an assembly line. The fungal cell is trying to build ergosterol. It starts with a precursor molecule called lanosterol. This enzyme 14-alpha demethylase is the worker on the line responsible for a crucial modification. It removes a methyl group from lanosterol to turn it into ergosterol.
And this enzyme is a cytochrome P450 enzyme. That becomes really important later.
Crucially important. The azole drug comes in and jams this enzyme. It binds directly to the heme iron in the enzyme's active site.
So the worker stops working, no ergosterol is made.
But it's actually worse than just having no ergosterol. It's what happens to the half-finished products. The precursor, lanosterol and other methylated sterols, start to pile up in the membrane.
They are the wrong shape for the wall.
They are toxic bad bricks. They disrupt the normal tight packing of the membrane. The membrane becomes fluid in the wrong way, the permeability changes, and all the membrane-bound proteins stop working properly. So the fungus simply stops growing.
So azoles are generally fungistatic. They stop growth rather than kill outright.
Generally, yes. Especially for yeasts. They arrest the growth and let the patient's immune system come in and finish the job.
Now we have a lot of azoles. The outline breaks them down by their chemical structure, the nitrogen count, imidazoles and triazoles.
This represents the evolution of the drug class. The imidazoles have 2 nitrogens in their azole ring. Ketoconazole is the prototype here. But honestly, if you were prescribing oral ketoconazole pills for a systemic fungus in 2026, you were doing it wrong.
Why is that? Because it's a legacy drug.
It is a dirty drug. Remember I said the target is a fungal cytochrome P450 enzyme.
And humans have an entire P450 system. The liver is full of them.
Exactly. Ketoconazole is not very selective. It hits the fungal P450, sure, but it also absolutely hammers the human P450 system, and not just in the liver. It inhibits the P450 enzymes that are involved in human steroid synthesis.
Steroids like cortisol, testosterone.
Both. If you give a man high-dose ketoconazole, you shut down his testosterone production. He gets gynecomastia of breast tissue, growth impotence, decreased libido. If you give it to a woman, it messes with her cortisol and adrenal function.
That sounds less than ideal.
It is terrible. Plus, it has highly erratic absorption. It needs a very acidic stomach, like a pH of 1, just to be absorbed. So if the patient happens to be on a simple antacid, the drug does literally nothing. So we have mostly relegated ketoconazole to topical creams and shampoos for dandruff.
So the real workhorses we use today are the triazoles, 3 nitrogens.
Correct. That extra nitrogen changes the shape of the molecule just enough to make it much more specific to the fungal enzyme, less toxicity to the human host. Not zero, obviously, but much less.
Let's go through the roster. This is where the clinical nuance really matters for the exams. First up, the one everyone probably knows, fluconazole.
Fluconazole is the specialist. It is incredibly good at what it does, but what it does is quite narrow. It is a yeast drug.
So we are talking Candida.
Candida and Cryptococcus. That is its absolute wheelhouse.
But it has a major blind spot.
A huge blind spot. It has absolutely zero activity against molds. If you have an aspergillus infection in your lungs, giving fluconazole is like giving them a glass of water. It does nothing. If you have mucor, nothing.
But for what it does cover, it is amazing. The sources absolutely rave about its pharmacokinetics.
It is a pharmacokinetic dream. It is highly water-soluble. And that means 2 really important things. One, it has nearly 100% bioavailability. You can swallow a pill or get an IV injection. And the drug levels in your blood are practically identical.
Which is great for stepping down and sending patients home from the hospital.
Huge advantage. And
Wow.
2, because it is so water-soluble, it goes everywhere water goes in the body. It penetrates the central nervous system beautifully.
So it's perfect for meningitis.
It is the maintenance drug of choice for cryptococcal meningitis, precisely because it crosses the blood-brain barrier so easily. And, as a bonus, it is excreted entirely unchanged in the urine.
Which makes it the perfect weapon for fungal UTIs.
Exactly. Many other antifungals are extensively metabolized by the liver before they ever reach the kidney, so there is no active drug left when it hits the urine. Fluconazole arrives in the bladder locked and loaded, ready to fight.
But we have to talk about resistance. There is a specific Candida species that just laughs at fluconazole.
Candida krusei.
Krusei. Sounds like cruise. It cruises right past the drug.
It is intrinsically resistant. It basically has a mutated version of the demethylase enzyme that the fluconazole molecule just doesn't fit into. If you culture C. krusei, fluconazole is immediately off the table.
And what about Candida glabrata?
Glabrata is the problem child of the group. It is not always resistant, but it has what we call dose-dependent susceptibility. It is very smart. It can rapidly ramp up those efflux pumps we will talk about later to just spit the drug right out of the cell. So often you see glabrata emerging in patients who have been on fluconazole for a long time. You might need a massive dose to overcome it, or you might need to switch to a different class entirely.
Okay, moving up the ladder. We need something that actually kills molds. Enter itraconazole.
Itraconazole is the step up. It adds mold coverage, specifically Aspergillus. And it is actually the drug of choice for the endemic dimorphic fungi, those like histoplasma and blastomyces.
But it is finicky, isn't it? The absorption profile seems like a nightmare.
It is the exact opposite of fluconazole. It is highly lipophilic, meaning it hates water. So just getting it into the bloodstream is a major struggle. We have two main formulations, capsules and a liquid solution.
And they have completely opposite rules for how you take them.
Yes, just to confuse every medical student and patient. The capsules need a highly acidic environment and food to be dissolved and absorbed. So you tell the patient to take it with a Coke and a heavy burger. The liquid solution, however, is already dissolved in a special cyclodextrin vehicle, so it actually absorbs much better on a completely empty stomach.
If you get that wrong, the patient gets no drug.
And the infection just gets worse. You actually have to check blood levels, therapeutic drug monitoring, just to make sure the drug is even getting into their system.
And there is a very specific toxicity warning with itraconazole regarding the heart.
Yes, and this is unique to itraconazole within this class. It is a negative inotrope.
Meaning it weakens the heartbeat?
It weakens the mechanical force of contraction. It carries a literal black box warning for heart failure. If a patient has a low ejection fraction or a history of congestive heart failure, you really want to avoid itraconazole. You tip them right over the edge.
Next on the list is the gold standard for mold, voriconazole.
Voriconazole. This was an absolute game changer when it came out. If you have invasive aspergillosis, a mold physically eating into the lung tissue, this is the drug you want. It penetrates tissues exceptionally well and it hits the mold hard. It effectively replaced amphotericin B as the first-line therapy for aspergillosis.
But Vori has its own unique personality quirks. The outline suggests a V mnemonic to remember them.
V for voriconazole. V for visual disturbances.
Visual disturbances, like hallucinations.
Sometimes hallucinations, yes.
Yeah.
But usually it is photopsia. About 30% of patients, that is 1 in 3, will report altered color perception, blurred vision, or seeing intense flashing lights.
That has got to be terrifying for a patient. Just sitting there like, doctor, the walls are flashing.
It is. It is caused by a transient blockade of specific ion channels in the retina. It is fully reversible. It goes away when you stop the drug, but you absolutely have to warn the patient beforehand, or they will panic and think they are going blind.
And what's the other V?
V for voracious metabolism, or perhaps variable metabolism. Voriconazole is cleared heavily by the liver, specifically by the CYP2C19 enzyme.
And human beings vary a lot in how much of that enzyme they have.
Exactly. It's genetic. Some people are poor metabolizers. They lack the functional enzyme. If you give them a standard dose, the drug builds up to massive toxic levels, leading to severe neurotoxicity and liver damage. Other people are rapid metabolizers. They chew up the drug so fast that they never reach therapeutic levels in the blood, and the fungus survives.
So you absolutely have to monitor blood levels with this one too.
Mandatorily. You cannot give serious voriconazole therapy without frequently checking trough blood levels. It is just too unpredictable.
And because it occupies that P450 system so aggressively, it interacts with, well, everything.
Everything. Warfarin, immunosuppressants like tacrolimus, statins. It is a pharmacist's absolute nightmare. If you start voriconazole, you have to meticulously review every single other pill the patient is swallowing.
So we have fluconazole for yeast, voriconazole for aspergillus. But what if we have those bread molds? The mucormycetes. Voriconazole doesn't work on them, does it?
No, it doesn't. In fact, we have seen tragic cases where leukemia patients on voriconazole prophylaxis develop devastating mucoinfections because the drug killed off everything except the mucor, essentially giving it free rein to take over. This is what we call a breakthrough infection.
So we need an even bigger gun, the newest generation of Azoles, posaconazole and isovuconazole.
These are the broadest spectrum azoles. They cover everything fluconazole and voriconazole cover, plus the mucormycetes.
Posaconazole started out as a liquid, right?
A sludge, frankly. It was incredibly hard to swallow, and it required a very high-fat meal just to be minimally absorbed. Thankfully, we now have a delayed-release tablet formulation that is much, much better.
And isovuconazole, the outline calls it the safe cousin?
Relatively speaking, yes. It is the newest one. It has a absolutely fascinating quirk regarding the heart. Most azoles, in fact, almost all of them, prolong the QT interval on an EKG. They can predispose you to deadly arrhythmias like Corsage de Pointe.
But isovuconazole doesn't do that.
It actually shortens the QT interval. This makes it a uniquely safe option if you have a patient who is already on other QT prolonging drugs, like certain antipsychotics or macrolide antibiotics.
And it doesn't have the kidney issues related to the IV vehicle, does it?
Right. 4-voriconazole uses a chemical solubilizer called cyclodextrin to dissolve it, which can accumulate and cause damage if the patient has kidney failure. Isovuconazole is formulated as a water-soluble prodrug, so it doesn't need that toxic vehicle. You can use it perfectly safely in patients with renal failure.
It sounds like the perfect drug.
Well, it is certainly expensive, and it is still an azole, so baseline liver toxicity is always a risk. But it is definitely the most refined tool we have in that particular shed.
Okay, so we have disrupted the membrane with polyenes. We have stopped the membrane construction with azoles. Now let's look at section 3 of our map. The wall breakers. The Echinocandins.
This class is my personal favorite because it represents a true, elegant breakthrough in selective toxicity.
Why is that? Because of the target itself?
Exactly. Remember the map we drew? Humans have cell membranes. Fungi have cell membranes. That is exactly why polyenes and azoles have collateral damage. But humans do not have cell walls.
We are soft.
We are. Fungi, however, have a rigid wall made of complex sugars, like glucan and chitin. So if you target the enzymes building that wall, theoretically, you should have practically zero toxicity to the human host.
And that is why they call it the penicillin of antifungals.
It is a very fair comparison. Penicillin kills bacteria by breaking their peptidoglycan cell wall. Echinocandins kill fungi by breaking their beta-glucan cell wall.
Specifically, they inhibit an enzyme called beta-1,3-AT glucan synthase.
Think of this enzyme as the master bricklayer. It spins individual sugar molecules together to make long chains of glucan, which then cross-link to form the structural mesh of the wall. The echinocandins drugs like caspofungin, mycofungin, and anigilofungin come in and basically handcuff the bricklayer.
So the wall gets weak.
It becomes incredibly flimsy. And because the inside of the fungal cell is naturally under very high osmotic pressure, that weak wall simply cannot hold it back. The cell essentially bursts open.
So for Candida, this drug is fungicidal.
It makes the yeast explode. It is incredibly effective. In fact, the echinocandins are now unequivocally the first-line treatment for invasive candidiasis, especially in the ICU setting.
Why specifically the ICU?
Because ICU patients are incredibly fragile. Their kidneys are often failing, so you do not want to use amphotericin. Their livers are congested or failing, so you worry about the azoles. Echinocandins. They're incredibly clean drugs. Very few drug interactions, very little organ toxicity.
But they work on molds too, right?
They do, but the mechanism plays out differently. It's fascinating. Against Aspergillus, they are merely fungistatic.
Why the difference? Wall is a wall, right?
It comes down to exactly where the glucan synthase enzyme is actively working. In molds like Aspergillus, the active growth happens exclusively at the very tips of the long filaments. The echinocandins damage these growing tips.
The apical tips.
Right, so the mold cannot spread any further. It is stunned. But the older parts of the mold, deeper down in the colony, have already built their thick walls. They survive the drug. So the echinocandin stops the active invasion, but it doesn't necessarily clear the entire organism on its own. We often use it as salvage therapy or in combination with an azole for really tough mold cases.
But there is a massive blind spot here, a huge gap in the armor that students always seem to miss on the board exams.
Cryptococcus.
Cryptococcus neoformans, the primary cause of fungal meningitis. It's a yeast. Echinocandins blow up yeast. Why don't they work here?
This is the exception that proves the rule. Cryptococcus is a yeast, yes, but it hides its cell wall.
It has a huge capsule.
A massive polysaccharide capsule. But even more importantly than the physical barrier, the core chemistry of its wall It's just different. It relies far less on beta-1 3D-glucan and much more on other complex linkages. So the specific target just isn't there in high enough numbers, or the drug physically cannot reach it.
So if a patient has cryptococcal meningitis and you confidently give them caspofungin,
You are treating them with a very expensive placebo. It is entirely useless.
also useless against mucor.
Correct. Mucormycetes have a completely different wall structure as well. They don't rely on beta-glucan in the same way. So echinocandins are very, very specific. Excellent for candida, good for aspergillus stasis, but totally useless for cryptococcus and mucor.
Got it. Now let's move deep inside the cell to section 4, the DNA saboteurs, the antimetabolites. We are talking specifically about flucytosine, or 5-FC.
This is a truly devious drug. It relies on a Trojan horse strategy.
How so?
Flucytosine itself, in its original form, is relatively harmless. It enters the fungal cell through a very specific door, a transport protein called cytosine permease. Humans do not have this door, so the drug actively concentrates inside the fungus while ignoring human cells.
Okay, so it's inside the walls. Then what happens?
Then the fungus makes a fatal, irreversible mistake. It uses its own enzyme called cytosine deaminase to convert the drug. It turns 5-FC into 5-FU.
5-FU, as in 5-fluorouracil, the heavy-duty chemotherapy drug.
The very same one. The
Yeah.
cancer drug. So the fungus unwittingly turns a harmless little molecule into a potent chemotherapy agent right inside its own nucleus. This 5-FU then aggressively jams up DNA and RNA synthesis.
That is brilliant molecular design. But if it is so smart, why is there a strict sidekick rule with this drug? Why can we absolutely never use it alone?
Because fungi are incredibly quick learners. Resistance develops almost instantly if you try to use flucytosine as monotherapy. A single point mutation in either the permease store or the deaminase enzyme, and the fungus is totally immune. So flucytosine is the Robin to amphotericin's Batman. You always use them together.
Usually for cryptococcal meningitis, right?
Yes. That exact combination, amphotericin B plus flucytosine, is the gold standard of care for the induction phase of cryptococcal meningitis. The amphotericin punches the hole in the membrane to let massive amounts of flucytosine in, and the flucytosine sabotages the nucleus.
But even though it is a Trojan horse, it does have toxicity, significant toxicity in humans.
It certainly does. Remember, the active form, 5-FU, is a potent cancer drug. If high levels of flucytosine accumulate in the human body, usually because the patient's kidneys aren't clearing it properly, some of it can actually be converted to 5-FU, possibly by the natural bacteria living in our own gut.
And then you get systemic chemotherapy side effects, like bone marrow suppression.
Exactly. Leukopenia, thrombocytopenia. You risk completely wiping out the patient's immune system, which is literally the last thing you want to do during a severe fungal infection. So you have to monitor the patient's blood counts and drug levels very, very carefully.
Let's move to section 5. The nail specialists. The Allylamines. The big one here is terbinafine.
You have probably seen the commercials for this one. It is the go-to for onychomycosis, those stubborn fungal nail infections.
How exactly does it work?
It hits the exact same general pathway as the Azoles, the ergosterol synthesis pathway, but it hits it much earlier in the assembly line. It inhibits an enzyme called squalene epoxidase.
Squalene. That name sounds familiar.
It is a very early precursor molecule. When you block this enzyme, the fungus obviously can't make ergosterol, which is bad for it.
Right.
But what is far worse is that the squalene itself starts to pile up massively.
Yeah.
And squalene, in high concentrations, is directly toxic to the cell.
So it is the accumulation of the garbage that actually kills the cell, not just the lack of the final product.
Precisely. And the real reason it is the nail specialist comes down to pharmacokinetics. Terbinafine absolutely loves keratin. It concentrates heavily in the skin, the hair, and the nails, and it stays there for weeks, sometimes months, after you actually stop taking the pill.
So it is perfectly designed for those dermatophytes that literally eat keratin for a living.
Exactly. Ringworm, jock itch, athlete's foot, toenail fungus. That is its clinical niche.
All right, we have covered all the major drugs. Now we need to look at how the enemy fights back. Section 6, resistance mechanisms. The ongoing arms race.
Fungi are constantly evolving, just like bacteria do, and they use surprisingly similar tricks.
The first one Murray lists is the efflux pump.
The spit-it-out method. Fungi possess CDR genes and MDR genes that encode these sophisticated transporter proteins. These proteins sit right in the cell membrane and literally pump the drug back out into the environment as fast as it comes in. This is a major mechanism for Candida libratus resistance to the azoles.
Then there is target alteration. Changing the lock so the key doesn't fit.
Right. If the drug is a specific key designed to fit a specific enzyme lock, the fungus simply mutates the gene to change the physical 3D shape of the lock. For the azoles, that means mutations in the ERG11 gene, which is the gene that codes for the 14-alpha-demethylase enzyme.
And what about for the Echinocandins? Can they mutate that target too?
Yes, through FKS mutations. The FKS gene codes for a subunit of the glucan synthase. If that mutates, the echinocandin simply cannot bind to the enzyme, and the fungus just keeps happily building its wall.
And we really cannot talk about resistance today without highlighting Candida auris again. The Jowett supplement calls this an emerging pathogen, but as we discussed, that feels like a massive understatement.
It is a bona fide global health threat. Candida auris is terrifying for 3 distinct reasons. 1, it is frequently multi-drug resistant. We have seen strains that are pan-resistant, meaning they're resistant to all 3 major classes: azoles, polyenes, and echinocandins. 2, it is incredibly hardy. It persists in the environment for weeks. It lives on bed rails, blood pressure cuffs, floors, catheters. It is notoriously hard to clean with standard hospital disinfectants.
And the third reason?
It causes massive outbreaks in healthcare facilities, spreading rapidly from patient to patient. That behavior is highly unusual for Candida, which usually just comes from the patient's own gut flora.
So it acts like a hospital-acquired superbug, but it's a fungus?
Exactly like MRSA, but fungal. And to make matters worse, it is notoriously difficult to accurately identify in the standard clinical lab. It frequently gets misidentified as other, less dangerous Candida species, unless you are using advanced mass spectrometry.
Let's look out at the horizon then. Section 7. Future and investigational agents. Is there hope coming down the pipeline?
There is hope. We actually have some completely new classes entering the field. One exciting one is ibrexafungerb.
That is quite a fun name to try and pronounce.
It is a tridopene. It works on the exact same target as the echinocandins, the glucan synthase, but it binds to a totally different spot on the enzyme. That means it can successfully kill fungi that have already developed those FKS mutations and are resistant to regular echinocandins. And crucially, it is orally bioavailable.
Which is huge, right? Because regular echinocandins are strictly IV only.
Exactly. So this finally opens up the possibility of treating severe resistant yeast infections at home without needing a PICC line.
And what about the Allylamines?
This represents a completely new mechanism of action. It targets pyrimidine synthesis, specifically inhibiting an enzyme called dihydroorotate dehydrogenase.
Why is a new pathway so exciting for clinicians?
Because since it relies on a completely new pathway, there is zero pre-existing cross-resistance. If a mold is heavily resistant to all azoles and polyenes, the aurotamide should still wipe it out perfectly. It looks incredibly promising for highly resistant Aspergillus infections.
Before we wrap up the future section, let's touch on a key concept for the exams: synergy versus antagonism. We already mentioned using Flucytosine together with amphotericin B as a classic example of synergy. But why don't we just throw everything at a sick patient? Why not give amphotericin B plus a heavy azole at the same time?
That is the classic board exam example of theoretical antagonism. Think about the mechanisms we just went through. Amphotericin B works specifically by binding to existing ergosterol in the membrane. It absolutely needs that ergosterol to be there to act as an anchor to punch the hole.
And azoles work by aggressively preventing the production of that exact same ergosterol.
Exactly. So if you give an azole first, you actively deplete the very target that the amphotericin B relies on. You are effectively disarming your own heavy artillery.
That makes perfect logical sense. You simply cannot target something that you have already chemically removed from the battlefield.
Now, in clinical practice, the data is a bit mixed on whether this antagonism severely changes outcomes in real life, but theoretically, and definitely for your exams, it is antagonistic. On the flip side, using terpenophyne plus an azole can be highly synergistic because they hit 2 completely different steps in the exact same pathway, like setting up a double roadblock on the highway.
So what does this all mean for the listener? Let's recap this entire chess match as we move into our outro.
It really is a complex game of strategy. We have 3 main biological battlegrounds. 1, the cell membrane. We can physically disrupt it with the polyenes, like amphotericin, or stop its construction with the azoles, like fluconazole and voriconazole, and the Allylamines, like terbinafine. 2, the cell wall. We smash the bricks with the echinocandins, like caspofuncan. And 3, the nucleus. We sabotage the DNA machinery with flucytosine.
And the overarching clinical pearl for anyone studying this is always treat the patient, not just the isolated bug.
Always. You must look at the host. If their kidneys are failing, you stay far away from amphotericin. If they have a central nervous system infection, You need a drug that actually crosses the blood-brain barrier, like fluconazole or voriconazole. If they are severely neutropenic and hemodynamically unstable in the ICU, you reach for the Echinocandins because they are rapidly fungicidal and incredibly safe.
And if it is just a simple, annoying nail fungus...
Serbenifine. Do not use a cannon to kill a mosquito.
All right, are you ready for the rapid-fire recall round? We've got 7 high-yield, single-best answer questions. To lock this knowledge in, I will ask the question, we'll pause for a second so you can think, and then we'll give the answer in the walk.
Let's do it. I'm ready.
Question 1. A patient with invasive aspergillosis is started on antifungal therapy, but heavily reports seeing flashing lights and blurry vision. Which specific agent is responsible for this?
Voriconazole. Remember the mnemonic. V for visual disturbances. It is a very classic side effect of the drug of choice for aspergillosis. If you need to review this, it is thoroughly covered in the Azoles section of Murray Chapter 61.
Question 2. Which antifungal class specifically targets β-1,3-D-glucan synthase, physically disrupting the fungal cell wall?
The Echinocandins. Drugs like caspofungin and mycofungin, they are our wall breakers. You should absolutely review the Echinocandin section to really nail down the difference between their fungicidal and fungistatic activity depending on the organism.
Question 3. A patient has a confirmed case of cryptococcal meningitis. Why is caspofungin not an appropriate treatment option for them?
Because Echinocandins have absolutely no clinical activity against Cryptococcus. Even though Cryptococcus is a yeast, its unique wall structure and thick polysaccharide capsule make it intrinsically resistant to this entire drug class.
Question 4. You are treating a patient whose culture comes back positive for Aspergillus caris. Which antifungal is intrinsically ineffective against this specific species?
Amphotericin B. Remember the word association. Terius equals earth. Earth equals grounded. Grounded equals resistant. It is the specific Aspergillus species that completely laughs at amphotericin. Check the Polyenes section for that exception.
Question 5. What is the highly specific mechanism of action of terbinafine?
It is the direct inhibition of squalene epoxidase. It severely blocks the early step in sterol synthesis, leading to that massive toxic accumulation of squalene inside the cell. This is detailed in the Allylamines section.
Question 6. Which specific yeast species is intrinsically universally resistant to fluconazole?
Candida krusei. It is the major gap in fluconazole's armor. Murray heavily highlights this specific exception in the Azoles spectrum discussion.
On the final question, question 7. Flucytosine is converted into 5-fluorouracil inside the fungal cell by which specific enzyme?
Cytosine deaminase. This is the crucial enzyme that humans lack, which provides the selective toxicity at least until the gut bacteria get involved. Take a look at the antimetabolite section to review that Trojan horse mechanism.
Excellent. That completely wraps up our deep dive into the antifungals.
It is a notoriously complex field, but honestly, if you just stick to drawing out that cell envelope map we talked about, you can navigate any clinical scenario.
And here is a final, slightly provocative thought to chew on before we go. We talked endlessly today about how hard it is to find unique targets to kill fungi, because they are eukaryotes just like us. But what if the next great breakthrough in antifungal therapy doesn't actually try to kill the fungus at all? What if we target their virulence factors, instead simply stopping the fungus from sticking to our human cells, or stopping it from changing its shape to invade tissues rather than trying to outright execute it, just chemically disarming it?
That really is the next frontier. Disarming the enemy instead of destroying the entire battlefield. It would completely bypass the selective toxicity problem.
It is fascinating to think about. Thanks for listening, everyone. We will see you all in the next deep dive.
Stay curious.